Yeah, look at this. They all just kind of come in last minute. Yeah, it's like they're used to being in broadcast news.
Yeah, on time.
We're on time, man. We're
Yeah,
just I think we should get started.
that's right, on budget. Yeah, so.
Awesome. So, welcome everyone. My name is Zak Holdsworth, and I'm honored to be here representing the Livestream, which Hint Health is sponsoring. I'm one of the co-founders and CEO of Hint Health. And so I'm sort of glorified tech support today. But anyway, we've got a pretty cool setup here. So it's a great honor to introduce Jay Keese, who's going to be going over the agenda and facilitating our conversation today. So over to you, Jay.
Great, thanks, Zach, and thanks to him for being such great partners in this effort. And I was telling Maryal the other day, I have an iPhone 10 XR. It actually inside has a rotary dial and so that I can use it. So we're really glad to have the not only the moral support and the important support you guys bring, but the tech support to be able to do our first hybrid DPC Coalition Steering Committee meeting. But more excitingly to me, this is our first in-person meeting since the pandemic, and it's been really hard to herd all the cats to get everybody here when Congress is in town and do the things that we did before the pandemic shut everything down. And I don't think it's a coincidence that the pandemic really did prove the case for DPC in a huge way. Because I will tell you, before the pandemic, when we go in and we talk about the value equation of DPC and not only in-person visits but virtual visits, with a person who actually knows your name the minute you walk into the office, how much that means to people who have gone through a global pandemic, we're going to be hearing a lot about that. We're going to spend some time today talking about the legislation. We're in this room today because we outgrew our small conference room in our offices, but tomorrow morning at 8 o'clock, we'll have our fly-in as well. So we're going to be in Suite 840. It is on the agenda that you have in front of you. So don't come to this room tomorrow. You'll need to have a little bit of time tomorrow morning to sign in, because I thought we could get those cards that Julia handed out to you to work for 2 days, but I guess it's too secure a building for that. So a couple other little housekeeping items for people who are here. Bathrooms, take a right out of this conference room and a left at the flags. And they're right down the hall. So if anybody needs a restroom, it's there. Like we usually do, we're going to spend some time going around the table and talking to folks about what's going on in their practices in their lives and just doing general introductions for folks. But first, I'd like to kick it off to our founder, Dr. Garrison Bliss, the godfather of DPC, to welcome everybody, and then we'll go around the table and do some.
Thanks, Jay.
Thanks, Garrison.
Welcome, everybody. It's nice to see all of the kids home for Christmas. And we're going to have a lot of fun today and tomorrow, I hope. So when I started my first DPC practice, I was 47 years old. A week from today, those digits will flip. And I will be 74. During those years, I've had the honor and the privilege of helping to lead the DPC movement and meeting many of the people who would grow this type of care, like you folks, from a 2 doctors in an office in Seattle idea to its current dimensions. At this point, I realized how naive I was when I started down this road, thinking that I would simply solve my quandary about how to provide optimized primary health care without going broke. Thanks to the efforts of hundreds of doctors, now thousands, I guess, both allopathic and osteopathic, and countless numbers of medical assistants, X-ray techs, nurse practitioners, receptionists, DPC organizations, attorneys, lobbyists, medical software engineers, business leaders, unions, school districts, news services, etc. This movement has moved forward steadily, despite plentiful obstacles. As we introduce ourselves today, it will become apparent that DPC reaches far beyond the realm of primary care physicians alone. However, the most important people without whom this would be impossible are our patients. They have helped shape the kind of care we give and reinforced our relationships with their sage advice, encouragement, and money. They have also made it clear that when we inadvertently deviate from the path, that something must be done. If we're smart, we will never forget whom we work for, no matter where the money comes from. In those same 26 years, I have learned more about American politics than I had ever wanted to learn. Thank you, Jay. DPC could have died in the crib had it not been for one person in particular, our host today, Jay Keese, who helped us in 2007 to navigate our way into the Affordable Care Act and subsequently through roughly 35 state laws with a small army of committed DPC docs, each moving out of his or her comfort zone to protect this movement and all that it stands for. Jay has also kept the conversation about DPC alive in Washington, D.C. through an era of politics that none of us expected and none of us as individuals could navigate without him. I also want to acknowledge Lisa Thatcher. You folks don't know her, but she is the lobbyist in Washington State who got us the first state bill. Flawed as it was, she risked her career. And in fact, when we finished, the head of the Health Committee in the House of Representatives said that refused to meet with her for 3 years, even though that's what she did was healthcare. We are here today to let you know that we have at least 2 bills capable of opening up the DPC playing field to millions of potential patients in need of what we have to offer: better care, better doctor-patient relationships, lower medical costs, and better health outcomes. As our name suggests, we are here to help steer this legislation that benefits both the movement and the country. If these bills become law, we will have accomplished something this week. This is where the rubber meets the road. Let's get to work. And the first job at hand is to have everybody do a quick introduction of themselves. You have probably 45 seconds each. I apologize, but Jay wrote the schedule. If it runs over a little bit, we can live with it. So we're going to go leftward and all the way around the table. Dave, you're first.
All right. Do you really want me to stick to 45 seconds?
No, you Dave gets a little dispensation.
Okay.
Yeah,
Thank you.
He's done a few things to help you.
We're doing some collaboration on our next fly-in, so I wanted Dave maybe gets a little grace at it.
Thank you.
So it's like, but everybody else, 30 seconds, that's it.
I hate to be a bit.
This will never work, but I said it, now let's go.
Yeah, so I'll try to keep it fairly condensed, but I went seeking for the solution to healthcare as a result of a personal journey with a friend that I've written about, I won't go into. And lo and behold, in my own backyard, I found what I thought was a microcosm of the future of healthcare, direct primary care. And I wrote a piece in Huffington Post and then Forbes that I think was Garrison's favorite headline, Health Insurance is Bunker Buster.
I love it.
Which was shortly after the ACA passed. And then I think I'm, without having had a dog in the fight at DPC, probably been the biggest advocate for it. I wrote the seminal paper on DPC, that was over 10 years ago now. I think there was a little bit of Zak's inspiration on him, came from some of the writing. And then when I launched Health Rosetta and sort of conceived of that, nearly a decade ago now, and we officially launched about 7 years ago, what we call advanced primary care or value-based primary care was at the core of that. What I described myself as at that point was an archaeologist, because I had to dig so hard to find things that were working. DPC was one of those. I found a few employers that I was working. Really now, I'm more Johnny Appleseed of spreading the good news, that there's actually things that work out there. And within the Health Rosetta community directly, we're responsible for about 5 million American lives. There's about 250 benefit advisors. And then by extension, it's about 10 million when you add in Health Transformation Alliance, which is kind of part of what we're doing with the jumbo employers. And then recently, I think of what we're doing is to some extent kind of air cover for your ground battle. So we haven't gotten engaged much in federal legislation, but there is there's 2 bills, one in the House, one in the Senate, that are around, ostensibly around transparency, but it's about a lot more than that, particularly the Senate bill. And we basically pulled together a letter that supported this bipartisan bill that's got conservative Republican Mike Braun out of Indiana and Bernie and a number of other co-sponsors. And I think it can put a lot of wind in your sails and make it kind of a no-brainer that you need to be doing these things. I think of it as kind of Archimedes' lever on this whole deal. The other thing I'd say is we have annual events that we put together. Last year was the first time we opened it up beyond our internal community, and we had over 100 clinicians, mostly physicians, mostly DPC physicians, and over 100 employers. And I really think of it as kind of this, we're at this point where we need market making, right? And I think of these events as cutting across the industry silo. We all can kind of you can go to your health IT convention, or your orthopedic convention, or your broker convention across the street, but trying to bring those together, because now we have the different pieces, right? And we have some critical mass. So definitely invite you to come to that. And that's in September, and we're syncing up on another fly-in. And just to wrap up, I come out of tech, there's this expression of eating your own dog food, of walking the talk basically. And our little company, it's about 12 people on our plan. The foundation of our employee health plan is direct primary care. So everybody gets that. And then we're, as much as you can kind of be self-insured in that space, we self-insure up to about $5,000 to $10,000, depending on family or individual, and then use a fully insured plan as kind of a quasi stop loss. So it actually works really well. And I don't have to tell you all how well proper primary care makes a difference. We haven't had claims go above that so far. At some point we will, but a big reason we haven't is because of great direct primary care. So
amazing. So I love that. I'm Maryal Conception. I'm a rural family physician out of Northern California and an extremely passionate DPC advocate. Every Sunday I host a podcast called My DPC Story about highlighting the physician experience in DPC, doing the things that Dave is talking about. And so I'm excited to be here, and Janine and I are going to be giving an update about what's going on in California.
I'm Janine Rodams. I'm a family physician in Santa Cruz, California. I've been practicing a DPC model now. This week completes 8 years, so we're going on to our 9th year. We are in the process actually right now of doing an expansion, which you can imagine California is kind of difficult to do, but we're working it. We are working on sort of a branch of the coalition now in California, which we'll talk about a little bit later. But we're excited to really bring California now to the plate of trying to move this movement forward. It's going to be slow but sure, but we'll keep going in that direction.
I'm guessing where it is. Mike Freeman, evolved DPC in Annapolis, Maryland. So,
Hey, Mike, could you speak up a little bit?
oh, terribly sorry. I have Mike Freeman, evolved direct primary care in Annapolis, Maryland, about 25 miles from here. This is our 10th year. July.
Matthew Hayden. I'm a family doc doing DPC right here in the metro area. I start off doing house calls only. Now I do have office space in Alexandria. So modern mobile medicine is my private practice, and pure primary care is my employer-sponsored network locally here.
Hey everyone, Sydney Hayes, co-founder, CEO of Mishi. My dad had a building company growing up, And I grew up seeing doctors and patients getting screwed over by the system firsthand. I was coerced to join his billing company right out of undergrad, scaled it, sold it, but the whole time I saw you guys all get screwed. And very early on wanted to create an ecosystem that allowed for patients to access care outside of the broken system. I saw what you all were doing. I was 17 in 2007, so sorry I couldn't get involved earlier on. But I saw what you all were doing and wanted to create an ecosystem to complement it, to allow specialists and facilities to engage in the direct care movement as well. So we built the legal and the technical infrastructure through which to do that. And now we're working on interfacing and connecting care providers, care sponsors directly with patients to cut costs and drive value and improve outcomes.
Me.
Yeah, that's it.
All right, I'm Fritz Busch. Hello, everybody. Thank you for inviting me to the steering committee meeting. I'm with Milliman Consulting Firm, and I'm going to keep my remarks here short because I've got 15 minutes to update you on our study that we're trying to conduct, a refresh of the original DPC study that we did about 4 years ago. So with that, I'll pass the torch.
All right, Natalie Williams. I'm the Senior Manager of Legislative Affairs at the American Academy of Family Physicians. So my spiel is pretty straightforward. I get to advocate on behalf of our very impassioned DPC docs, of which there are many. But the real star of the AFP show as it comes to DPC is Bethany. So I'll let her introduce herself.
Hi everyone, I'm Bethany Burke. I'm the Chief of Staff to the CEO of the American Academy of Family Physicians. I've been managing the direct primary care portfolio at the AFP for about 10 years now. So we've been doing this journey for a while. That includes creating a series of resources for our members, collaborating with our GR team and Jay on any DPC advocacy at the state and federal level. And then of course we do host an annual event every year in the summer called the DPC Summit that we have grown. It's now 3.5 days that really focuses on educating people to move to the model and helping those that are in the model expand. So yeah, it's nice to meet you all.
Tommy Barletta, I'm here on behalf of Bright Pay Health Corp. The CEO and founder, Shawanda Hayes, is on the virtual. She's founded this great app called Bright Pay, as I said, helps physician practices grow by leveraging connectivity with the freelance community. So happy to be here, and Shawanda's happy to participate as well.
Matt Hoff, I'm CEO of AS Meds. I get 15 minutes later, so I'll pass it down.
Paul Yerkes, I'm a family physician outside of Philadelphia, southeastern Pennsylvania, co-owner of Core Family Practice with Ricky Haug. We started in 2016. I joined in 2019, and we now have grown to 2 practices and about 5 physicians. I'm also the president of the DFP, trying to push DPC in my small state of Delaware that I live in. And yeah, happy to be part of this.
I'm Ricky Haug, and so started Core Family Practice 2016, 30 patients, and now we have 5 docs, 2 locations, and almost 2,000 patients. So it's been well received, and it's kind of hard outside of Philly. You know, it's there's not many of us. So.
In the mushroom capital of the world.
We're in the mushroom capital of the world. Yes, yes. Happy to be here.
Hello, I'm Michelle Neblett with the Boeing Company. I am in our government affairs shop, so I'm our lobbyist that advocates on behalf of direct primary care on the Hill every day. So it's great to be part of this meeting again. Jay, thanks so much for the invitation, and I too have some time later, so I'll save my comments for then.
Hi everyone, Sarah Lloyd Stevenson with Government Relations at Amazon, and I will let Mark speak to a bit later of kind of the Amazon vision around DPC with One Medical. But from a public policy perspective, I will say I've worked a lot across Amazon Health. I've worked on a lot of different healthcare issues on Capitol Hill, and I just think it's really exciting what everyone is doing here and that we get to lend our voice in support of DPC as we're on the Hill advocating every day. So thank you for having us.
My name is Lincoln Andreasen. I'm a family medicine physician at Pro Partners Healthcare in Kansas City. After 8 years of active duty Air Force service, I was frustrated with a primary care model that is essentially insurance-based, and I'm happy to report within this last year, separating from the military and joining this DPC practice has been everything that I was hoping that it would be. So I'm happy to come here and kind of broaden the scope, see what it's like at the national level and what issues that you're with my awesome colleague. Pass the baton on to.
I'm Troy Burns with Pro Partners Healthcare in Kansas City. Also founded that. Well, it was a transition from an insurance-based primary care practice. We're in our 11th year, I guess. So growing, looking for our 5th physician. Dr. Garrison is our 4th, and is a military guy named Lincoln who's never been to DC before. I figured we needed to bring him here, and so I got a picture of a couple Lincolns, together. We'll see how that goes. Introduce them to the movement a little bit.
Well, and I guess I stuck in here late, but Brent Trexelius with Millennial Health. I'm sure some of you have heard about us, but we've been fortunate to partner first with AS Meds to, it's an ongoing process, but to bring forward a pharmacy and vaccine solution for the DPC centers. And we have a few other things in the works that we'll talk about as well. Thanks for having me.
Thank you. Hey everyone, Jennifer Tomasulo. So I have a lot of history with embedding direct primary care with employers on the brokerage side. So I worked with NFP for many years, but most recently the Director of Strategic Operations within PeakMed and One Medical. So nice to be here. Thank you.
I'm Mark Tomasulo, family physician, founder of PeakMed Direct Primary Care, acquired by One Medical, and now Amazon, and I'm the head of direct primary care strategy and innovation for One Medical. So I'll talk a little bit later about all the things Amazon. Nice to be here.
Thanks, William. Initially, we've got someone online, so we're going to go to Clint. Perfect.
Hey, Zach, sorry about that. Can you hear me okay?
There you go, Clint.
Hey, listen, hello, everybody. Sorry I can't be there. And in about 10 minutes, I'm going to be in a much better spot where I can hopefully have a little better reception. So looking forward to listening to everybody.
Great, thanks, Clint. And yeah, my name's Zak Holdsworth, one of the co-founders of Hint. And per Dave's comment, was really inspired by a lot of the early work from folks like Dave and physicians that we were kind of running into and wanted to build a company to support the growth and success of the direct primary care movement, and are super excited to still be here trying to achieve that. So thanks for having me. Try.
Great. Hey everybody, sorry we're late. We're at least one meeting in terms of what we're trying to do here. Went well, I think. Yeah. You shine. So I'm a family doctor, direct primary care practice in North Carolina called Lantern Health. We are a 2-location, 8-physician group at this point. We started as part of a health system and transitioned out of it, so a little atypical in terms of how we started, but nonetheless, it's been a fun adventure. And then for a period of time, kind of helped oversee a health plan for a startup insurance company called Decent. And still I'm advising them as it relates to trying to build an insurance product around direct primary care. I'm really excited to be here.
I'm Tanner Moore. I am a farmer, just got out of the Army last month, so just separated January 1st, and opened a direct primary care practice in North Carolina right outside Fort Liberty. It's called Clearwater Health Direct Primary Care, and we're really focused on the business-to-business part of DPC. We want to empower businesses by helping put DPC as the foundation of their health plans.
And last but not least, I think, did we miss anybody else from the table?
Hi, I'm Julia Cooper. I've been Jay's intern for a little over a year now. I'm very excited to get some work done on DPC. It was the only bill that we saw, at least in a House hearing I went to, that passed through unanimously. So that was very exciting through the committee. So I'm excited to work with you all.
And you are a sophomore?
Yes, I'm a sophomore at American University.
Awesome. Thank you so much for being here.
Hey, we did that in less than 30 minutes. Good work. Good work. Excellent job.
Yeah, and if anybody wants to buy 2 or 3 minutes back, has more to talk about, I'm happy to throw it out
No,
here.
we're going to kill.
Otherwise, you're going to have to hear me talk for 5 more minutes.
No, don't do that.
Well, Julia really teed us up pretty nicely because I just want to throw a question out for the audience. What do we think about when we think about Washington DC today? Give me an adjective or something, anything.
Messy. Interesting.
Interesting.
Messy.
Messy.
Yeah, it couldn't suck any more than it does.
Anybody else?
Actually, to me, it's very quiet these days.
Quiet.
Because everybody's laughing.
I like the history, like almost immediately. It's great coming from the West Coast.
Well, nobody said bipartisan, right? Nobody said, getting things done, but we're super excited because this idea of direct primary care really has its roots in a very bipartisan sort of idea. And that idea is that, every man, woman, and child in America ought to have health care, right? What does that mean? Does that mean insurance? No, I don't think that's what we think it means. Certainly insurance is part of healthcare, but when we think about healthcare, what's the first person, and I'm going to ask one of the non-doctors to answer, what's the first person you think of? An insurance agent? A broker? Who do we think of? Think of a doctor. So the idea is, well, what if we could have every man, woman, and child in America afford to have a primary care doctor that actually, when you walked into the office or you called on the phone, whether it's rotary or like an iPhone 15, that they answered the phone and talked to you and knew your name and didn't have to spend 15 minutes looking at the chart to figure out who you are, and probably knows why they're calling, right, Matt, when you call.
Even if they're in Utah.
Even if they're in Utah. So, it's been really exciting for me as a healthcare lobbyist who spent over a decade working at the AMA, and I've worked for employer groups like the U.S. Chamber of Commerce and others. But when Garrison Bliss walked into my office in 2000, I think it was 2009, you're dating us a little bit back.
Yeah.
Maybe it was 2008.
But the Affordable Care Act, when did it pass?
10. So I think it was 9. So anyway,
I got the date.
he said, well, I'm a primary care doctor, and we can give all of our patients a full primary care benefit where they have same-day access to appointments. They can call anytime they want, and it costs them, I think at the time it was $50 a month?
30 to 60, depending on age.
Right.
Yeah.
So, and I just said, well, that's great. That can't be right, but you tell me how it works. And he did. And when I started to think about it, it really was, this idea the Affordable Care Act was moving forward. And in the confines of the Affordable Care Act, every man, woman, and child was going to get health care. What did that mean? They were going to get a health insurance policy, right? That was either going to be funded by the federal government or funded by an employer or funded by Medicare or Medicaid, the VA, TRICARE, any of these existing organizations. And within that, this little idea, this kernel of an idea that happened in Washington was probably going to get smushed, was probably going to get destroyed. Because you were going to have to get primary care only through your insurer. So this new model where you have a primary care doctor who takes care of you for a monthly fee, knows your name, knows your family, knows your history, could not work as a part of that construct. So what we were able to do then is put this provision 1301A3 into the Affordable Care Act, which says if you have a direct primary care medical home, was the term of art, but make no mistake, a direct primary care doctor practice, and a qualified health plan, the two of those things can work together to meet the requirements of the essential health benefit. So we are officially an essential health benefit of the ACA. Fast forward to President Trump being elected in 2016, and the very first healthcare policy announced by Seema Verma out of the Trump administration was, we want to bring DPC to Medicaid, and then eventually we want to bring it to Medicare. So, the administration of Barack Obama and the administration of Donald Trump agreed on something. They agreed that every man, woman, and child should probably have access to a doctor. We've moved forward, got the legislation in the ACA, actually, interestingly enough, with some help from some key Republicans, people like Mike Crapo, who's now the ranking member of the Finance Committee, said back then, this is a great idea. He went to Chuck Grassley. They talked to Maria Cantwell. This is a little Pacific Northwest conspiracy that got together. Then we worked with a bunch of other different members from Washington State to get this provision in the bill. And then we went around the country and we passed, after the Affordable Care Act passed, and we passed laws in 33 different states that essentially defined direct primary care as a primary care medical service outside of state insurance regulation to sort of meet those requirements in the ACA. And it was important to know that the Obama administration's rulemaking for the ACA said very specifically, DPC practices are providers, they are not insurers. So they do not fit in the rubric of the insurance side of the ACA. They fall outside of it, but they can still be considered a qualified health plan. And so, you know, when we put that provision in there, we found it fairly easy to go state to state and pass these laws. And I wouldn't say fairly easy, but it was overwhelmingly bipartisan. We had a situation in Virginia where we had to, we got kind of held hostage by a partisan argument about, well, if you want to do this, we consider that a Republican thing, and Democrats, we wanted to do Medicaid expansion. And you know, we got held up for a year, but eventually we passed the bill almost unanimously out of the House and Senate in Virginia at a time when Virginia was very divided. I think the same story happens in all of these states. And you know, we've done a good job. We have co-sponsors of legislation from Earl Blumenauer, who is the you know, head of the Cannabis Caucus and the Bicycle Caucus. And I would wager that probably among the most liberal Democrats in Congress. And we have Bill Cassidy, who's a conservative Republican from Louisiana, a gastroenterologist. He's a physician, and even though he's a gastroenterologist, loves the idea that primary care doctors ought to be able to do this in a way that meets the needs of their patients and their practice. So, and we worked, we worked very closely over the years trying to bring a DPC-like benefit into Medicare and even Medicaid. We're going to talk about it in a little bit. The ACO REACH program, which is very, very much not direct primary care, was originally an attempt to do direct contracting. And again, in the Trump administration, the idea was we were going to set up something different than Medicare Advantage, something different than the ACOs that were anticipated by the ACA, that would have more of a direct relationship with the doctor. So even in Medicare, CMS realizes what direct primary care is, which is it's groups of physicians providing medical services in a primary care setting outside of insurance. Today, there's really only one regulator in the world that looks at primary care as a form of insurance, and that would be the IRS. So, as Julia mentioned, I'm actually going to skip forward and to the next slide and talk a little bit about why, because there's a lot of questions why. And I think everybody in this room understands this, so we'll not spend a ton of time on that. But the eligibility rules for HSAs, this doesn't apply to any other part of even the tax code, let alone any other part of the law. The eligibility rules for health savings accounts are very specific. If you have a health savings account, it has to be paired with a high deductible health plan. It can't be paired with any other thing, any other form of coverage that looks like a health plan. So if it's not a high deductible health plan, which clearly DPC is not, and it's not an insurance plan, well, what is it? It needs a new definition in the tax code for them to be able to execute on this. So in the interim, the remedy here is, well, if you have a DPC agreement, you're not allowed to fund your HSA. So the reform that we're going to talk about in a little bit doesn't really have a whole lot to do with HSAs, to be candid. We're stuck in the HSA statute because it makes people ineligible to fund an HSA. Now, the last, I believe, Devenir report that I saw says about 53% of Americans today have a high deductible health plan that is eligible to an HSA. So the problem here isn't that you can't take the money out of the DPC, out of the HSA and spend it on your DPC. The fundamental problem we have is that 53% of people with health insurance in this country are not technically legally allowed to have a contract with a DPC provider. And that's what the bill, one of the bills that Julia referred to, that we're here to talk about today, would fix very easy and very simple. The Primary Care Enhancement Act, there's two versions of the bill, one's in the Senate, one's in the House. It would allow any taxpayer with a HSA qualified high deductible health plan to participate in a DPC agreement with some minor restrictions and still allow them to contribute to the HSA. We passed this bill in what was otherwise a very, very partisan session of the Ways and Means Committee, what's called a markup, where they actually mark the legislation up and move it forward. But on that day, when a couple of people in the room with me there, I don't think there was there another bill? There were a couple of other bills that got pushed together into one, but there really wasn't any bill that was heard that day that got the attention of DPC as being this truly bipartisan reform. So the Ways and Means Committee, actually I believe the third time since 2018, passed this bill, the Primary Care Enhancement Act, out of committee and moved it on towards the floor of the House of Representatives. Earlier that year, Representatives Dan Crenshaw and Kim Schreier, a Democrat from Washington State, who is also a pediatrician, passed a bill that would also clarify that CMS, the agency that runs Medicare and Medicaid, could do a direct primary care agreement with a state that wanted to do this in the confines of Medicaid without going through a months to years long waiver process. So what we have here are two efforts that have both passed. This bill particularly passed unanimously, 28-0 on the 13th of July of last year. So, the Congress is speaking pretty loudly here, to me anyway, saying that, the people that run these healthcare committees really believe that regardless of whether you're wealthy, whether you're in Medicaid, whether you're in Medicare, people ought to have access to a DPC agreement. So fundamentally, the bills that we're talking about here don't really have a lot to do with HSAs, and candidly, they don't really have a ton to do with Medicaid. It's just allowing anybody, regardless of the modality of their insurance, should have access to this kind of care. There are states that want to do Medicaid. The state of Michigan requested that they have a Medicaid DPC plan. We've actually tried this in Washington State, and we've learned some really important lessons. So I think what's important about the Medicaid Primary Care Improvement Act isn't that it mandates that states do DPC and Medicaid. It doesn't force any doctor to take Medicaid patients in any way, shape, or form. It allows the people that are sitting around this table, the stakeholders involved in direct primary care, to come together and work with their states and to work with CMS on what would the best pathway forward be. That pathway is going to look different in California or Colorado, which currently effectively bans Medicaid patients from even paying out of their own pocket to go see a DPC provider. Those arrangements are going to look different in each state. So rather than doing this cookie cutter, this legislation would allow us to have a conversation with states, to have a conversation with Medicaid, at the federal level at CMS, about what this would look like. And we think that's incredibly important because it is not a one-size-fits-all solution. There are lots of pitfalls that Garrison can talk to you about how Medicaid can work with DPC and how it cannot. But I think it's fair to say when people in Washington State in Medicaid had DPC, they liked it a lot and they did really, really well.
5-star reviews from Medicaid patients. We reduced the cost of Medicaid by about 20 to 30%, which they interpreted as a mistake on their part. They gave us too many healthy patients. They didn't actually look into it very well. So they thought that $10 per member per month might be excessive. So that's what happened to our effort. But the Medicaid needs to think about where they're going to get primary care at this point. And they have done everything they can to kill primary care of all stripes. So now the question is, can they stop killing primary care? We have some ideas, but we have to be able to talk with them, and they have to understand what we're doing. And we're not just taking care of rich people, and we don't want that.
Yeah, I think that's critically important for people to understand, because I can understand with doctors around the table and with Medicaid directors around the country, there's some trepidation about this. Is this concierge care? Is that going to fit? Is it going to be super expensive? Lots and lots of different questions. I think we have answers to those questions. We have data to put behind those answers that I think we can extrapolate from the work that Milliman and the Society of Actuaries has done, and we're going to be doing that. You have two handouts, and I think they walk through these arguments nicely. And I think one of the points, the lighter blue one is about the Primary Care Enhancement Act, and the darker blue one is about the Medicaid bill. One of the points we hear a lot on Capitol Hill is, and particularly from our Democratic friends, is that HSAs are for the wealthy and the young and the healthy. And so, we don't want to do a whole lot to, improve care for that group of people when we've got these problems with shortages of primary care doctors and Medicaid, for instance. So I think we're coming to the table with a two-fisted solution. We understand that some of you are going to be, more likely to want to talk about the Primary Care Enhancement Act than the Medicaid thing, A, because it's new, and B, because it's got lots of questions. But what this really allows us to say is, look, we're here to advocate not only for bringing, good primary care to what, if you consider them younger and healthier and more wealthy, the younger, the healthy, the more wealthy, but also to people in Medicaid. So we have two solutions, and they have drastically different methodologies potentially in terms of how the care gets delivered. But the reality is that it's the same idea. In a time when both of these talking points go through this, in a time when we have a shortage of primary care doctors, we ought to be doing more to actually get that level of primary care to the people. And I don't know if our friends from AFP, I don't want to put you guys on the spot, I have any data about this, but there's not a ton of growth in primary care today, vis-a-vis some of the other specialties, but there continues to be really good growth in DPC. And so we do see this as not the answer, of course, but an answer and a way to move forward and potentially a way in the next few years to address these critical primary care shortage areas. And we have a map of the healthcare primary care shortage areas that's in here. In these purple areas, we have DPC doctors. They would see Medicare patients, but they're probably not going to see them for $5 a month. So we collectively sort of have to figure out a way, states and the federal government, to figure out how that moves forward. But we see these bills not linked together right now. They're not. But there is a linkage. And again, that linkage that you can draw when you're talking in your meetings is, no, we're not here just to lobby for the wealthy, the young, and the healthy. We're here to get DPC in, certainly for people that have high deductible health plans who really need a DPC doctor as well, but for people in Medicaid as well. So the two have a connection there. And I'm glad to report, and I'm going to lean on Fritz a little bit to talk a little bit more about this. We won't spend a ton of time talking about this. I'm glad to report that one of these bills has come through that committee process with what essentially a 0 score, which means that it isn't, the Congressional Budget Office in this case does not anticipate that the stakeholder convening piece of this will cost the federal government any money at all. As I think you're all aware, having been here before, we've had a slightly different problem with the Primary Care Enhancement Act. And you'll hear people say, well, it's expensive. It costs $2 billion over the course of 10 years, 2.037 billion to be precise. Well, I'd like to point out, as was pointed out in our markup a couple months back, that's really not the case. It isn't a bill that costs anything. What this bill does functionally is the Joint Committee on Tax, which is given it this expensive number of $2.037 billion, is saying that the IRS will not collect $2.037 million in new taxes. That Americans will in fact get to keep that $2.037 billion and spend it on pre-tax preferred qualified health expenses, including direct primary care. So if somebody says, well, this bill is really expensive, it costs a lot of money, I mean, I think that's an answer. The answer is that it doesn't really cost a lot of money. There's some tax revenue that the congressional budget, that the Joint Committee on Tax agrees is not going to be collected by the IRS. And the IRS doesn't like that. They want to collect as much as they possibly can. We understand that. But, wouldn't that money be better spent on giving, potentially 53 million or 53% of people with employer-sponsored or work-sponsored health coverage a direct primary care benefit? Right now, we're going to hear from Boeing. It's just something we can't do in a group of people that has a high mix of HDHP, HSA plans. So that's what we're here to talk about. And clearly, you're all free to talk about whatever you want. I think tomorrow, for tomorrow's purposes, we're going to spend, we're going to want you, the physicians in the room, to really spend a lot of time telling your story. These handouts, we hope we have extras as we gather tomorrow to head off to these meetings. We'll have an opportunity to talk about those. But it's really important that they put your faces and your stories with what's happening here in this movement. Because there is, since the pandemic and the fact, again, we've passed this bill out of committee a number of times before, there is growing familiarity with DPC. There's still quite a bit of confusion between DPC and concierge plans. In fact, we all know there are these $150 limitations on what would qualify for this exception in the tax code under HR 3029. That is largely there so that expensive concierge plans for the wealthy actually do not qualify for this tax benefit. And JCT and the Ways and Means Committee, both Democrats and Republicans, sort of agreed, we're willing to give this $2 billion worth of a tax break to people so they can do this, but in a DPC arrangement that's affordable, not in a more expensive concierge arrangement. Now, the language isn't really written that way. If the concierge plan falls outside of that, and it does, it isn't impacted by this bill at all. It's the same. There's no change. But the reality is, the bill that we're here to talk about would really open up a new pathway, a new exception under the tax code to create a DPC benefit that does not cause people this conflict with their high deductible health plan and HSA. It's a pretty important piece of legislation. It could be game changing. And I think what we've seen, the uptake from employers, if most of these employers are offering HSA plans, they really have their hands tied. Brokers, HR people, lawyers are not going to allow them to put together contracts that have a DPC agreement in them unless this is changed. We've tried to change this at the administrative level a couple of times. We got a very good ruling out of the Trump administration on the idea that we kind of knew before, that direct primary care, if it's the practice of primary care medicine, is in fact qualified health expense under the tax code. It is still a qualified health expense that doesn't enable you to fund an HSA. So ironically, the position it puts us in now is, hey, you can have an HSA, but if you have a DPC, you can't put any money in the HSA. So it really doesn't work. It's kind of a catch-22. And the IRS looked us right in the face and, essentially said, you got to change the law. And that's where we are. So really happy everybody's here today. I know there are going to be some questions. I think we'll hold those until the end, so we have an opportunity to ask some questions around the legislation. But I want to continue the dialogue now and move over to Michelle to expand a little bit about what employers, and we have one of the largest employers in the world here to talk about it, think about DPC and the efforts that you all have put into our advocacy as well. And I thank you, Michelle Neblett from Boeing, I thank you for being here, and we'll turn the floor over to you.
Well, thank you, Jay. It's, as I said, it's great to be with you all again and happy to be in person. I was thinking about the last time I think I was with you all, it was in your office, Jay, and it was pre-pandemic for sure. So it's been a while. You know, a lot of you know Boeing's story. We are have been committed to value-based care for a long time. We've been down this path since early 2000s, mid 2000s, I would say, when we did our study around medical homes in Puget Sound in Seattle, and found that, you know, this coordinated team-based primary care really had the ability to reduce costs and improve health outcomes, and importantly, internally for us, a huge improvement in productivity. And we have used that data to then go forward all these years later and continue to prove the ROI to our leadership, and continue the investments in preventative care, early care, so that down the line we avoid the ER and hospitalizations. You know, we've been doing direct primary care in Mesa, Arizona since 2018, and that was about the time that our benefits team called me and said, hey, there's this piece of legislation we've got for you to work on in DC, and that's when we got involved with the Primary Care Enhancement Act, and we've been doing that ever since. My job at the company, as I said, is government affairs, so I'm our federal lobbyist on employee benefits. I do spend probably 75–80% of my time on healthcare, and 75%, 80% of that time is spent on DPC on this bill. So it is our highest health priority for the company. It is the thing that we want to see achieved this year in Congress, barring everything else, that all the other noise. So I'm up there every day lobbying on this, telling our story, talking about how it really is, to Jay's point, about the care. It's about how we want to see, we truly believe this is the way primary care should be, that it's about the relationship you all have with your patients, and that building of trust, and how that leads to better prevention and better primary care. We have built, you know, off the learnings that we had from our direct contracts we did with integrated hospital systems. We were, quite frankly, disappointed that more employers didn't follow us into those. But those are really complicated, complex undertakings. They take a lot of consultants, they take a lot of lawyers, a lot of time, and we really believe that one of the things about this legislation is that smaller employers, a lot of other large employers even, can easily get in the value-based care game, get in into direct primary care once this legislation is passed. Because, to Jay's point, so many of us employers do have, you know, the high deductible HSA plans. So we really talk about how this opens a door to a lot of smaller employers. I think that's a message that is well received on the Hill. Small employers are, and their plight. And so, you know, I think it's something that that you can come at it from all these different angles. From Boeing's perspective, you know, this, as I said, we've had our arrangement in Arizona, first with IORA and then One Medical, since 2018. And, you know, we're looking to expand around the country. We have, we insure, we're not quite as big as Amazon, but we self-fund and insure more than 450,000 lives nationwide, both active employees and their dependents, as well as early retirees and their beneficiaries. And so we're in every state. And so we are not all in Washington State, which is our largest employee base, but we're in every state. And we're looking to bring this type of care to every single employee and their family.
How long have you been self-insured?
We've been self-insured all along. I couldn't tell you when that started. It's been
It's before the B-17, I'm pretty sure.
I'm sure. I'm sure. And so, we're a jumbo, right? We're kind of in a bigger category, but yeah. So we're looking at ways to do this, and more than 40% of our population of our employees choose our high deductible HSA plan every year. And so, it is a fairness question for us. It is a scalability question for us, and we need this legislation to be able to do that. And so that's why we're very passionate about this legislation. We're passionate about what you all do every day, and want to see the ability to expand that nationwide. As I said, we'd love to see other employers follow us into this and join us. And I know there are certainly a lot around the country that have, but really in a groundswell sort of way. And so, we work with our trade associations, employee benefits trade associations, the ERISA Industry Committee, or ERIC, the Benefits Business Group on Health, which is also another large self-funded employer group. We have a coalition called the Corporate Healthcare Coalition. It's a group of about 9 large self-funded peer companies that work on employer healthcare issues that are in it for the healthcare policy. And so that group advocates on this bill. We work with Purchaser Business Group on Health, which has been a leading advocate with us and working with us on, especially in the Upper Northwest, on medical homes and pursuing advanced primary care models. We work with family physicians, the NFIB, small businesses, a whole host of groups, and of course the brokers. So, there's a large group of folks around the table who talk about this policy and are advocating and come at it from different angles from the employer voice. So, as Jay said, tell your story this week. Your stories about how you've changed your patients' lives, how you've improved their health, how they view healthcare differently because of the care that you provide. I know we have those stories from our employees. Those are really powerful, and those are really great messages to leave with the staff and the members this week. And that can really make a difference in terms of talking about what this is. And it's not about the tax code. It's not that just happens to be our hurdle. It is about providing this care and offering this care to millions of Americans. So thanks for being here, and thanks for your partnership.
Thank you, and I will say, how long have you been doing this? It's like 6,
I've been
7
at Boeing since 2017. We started in 2018.
Yeah.
It was like January or February of 2018.
It was very lonely before Michelle came in. You were looking at him, but she, it's so important. Not only the story that Michelle's told today about the scale and the size of what Boeing wants to do, all the way down to Clint and his folks at Left Hand Brewers in Colorado that have a couple hundred employees that want to do it, down to the corner gas station in Florist that want to do it as well. But the team that Michelle has put in place to help us on this has really been second to none, and has really helped us move this forward. AFP also, weighing in with these great resources over the years. Numerous of some of the best lobbyists in town have been up there on Capitol Hill on behalf of AFP, Boeing, and now Amazon as well. And Amazon has a huge history with DPC. I don't think it's lost on a lot of people in this room, and we've had conversations with some of the folks at Amazon, Sarah Lloyd recently, about about this as well. You know, one of the original investors in Q Alliance
In
was.
Q Alliance, yeah, Jeff Bezos was one of our investors. Because he and Nick Hanauer were good friends, and Nick was our first investor and Amazon's first investor. So that was the commonality.
Wow.
And also, I mean, I'm not sure how much Jeff understood about what we were doing, because he didn't actually come to the meetings, he said somebody else. But he believed that Nick was onto something, and enough to hire somebody to go to work on this problem, and also to begin to think about what this could do for them, and also for their customers.
So we're really excited to have Amazon One Medical at the table. They have renewed their commitment to be a part of this coalition through the mergers that have happened here recently. We're super excited. I've known Mark Tomasulo for at least 10 years, and one of the pioneers in DPC in Colorado, which has been one of our hotspots. And I'm going to turn it over to Mark a little bit. And I'm just going to get this out on the table, because I put something up on LinkedIn the other day about this meeting happening, and it devolved into a conversation about whether or not Amazon is in fact DPC. Amazon One Medical is in fact DPC. And I think I would love, Mark, and to the degree that Sarah Lloyd wants to jump in at any point, I would like you to tell us about that. And I know I'm actually a big fan of Amazon Prime. I wouldn't have made it through the pandemic without it. And I know there's lots of big box kind of stuff that you can get at Amazon, and there's lots of things, you know. I bought a mustache comb from a guy in Peoria on Amazon. So there's lots of different ways to provide and deliver healthcare. And I know you all have different ideas about these things. And Mark, I would love to turn it over to you and talk a little bit about Amazon One Medical and the changes that are happening over there, and your role, and what that commitment to DPC is all about.
Yeah, absolutely. Well, first, thanks for having me. And I think it might be beneficial just to give a little bit of background really quickly. So I started my practice back in 2014, consumer-based practice, and I was 12 years military, so Army, go ahead. There is light at the end of the tunnel. I think for me, I was sick of the system. I was extraordinarily burnt out. I got out of the Army, went into the ER. I did a lot of trauma medicine in the Army, so the ER was natural gravitation, urgent care, but I'm a family physician by training. DPC was this thing that was like a little flicker of like, there's actually an alternative here that makes my life a little bit better, gives me back autonomy, gives me control, or at least maybe a self-perceived sense of autonomy inside of direct primary care. And so I set out on the journey, started on a consumer basis. Very quickly, we got a very small company. And I would say within probably a year, we were at a break-even point financially, but we had flipped the switch into the employer space. Fast forward several years, we're an organization that was probably 80% employer-based, 20% consumer-based. We had 350 employer accounts. We had 5 locations, brick and mortar at that point, but I built out a national network of DPC practices. We have about 100 today. We have about 160, 170 national affiliate contracts that we manage behind the scenes, and just trying to help patients connect with employers. And so most of our employers are not geographically concentrated. They're national employers. There might be 10 over here and 100 over here. And, you know, as an entrepreneur and paying bills, you say yes a lot to a lot of things, and then you figure it out. And so that network became this massive labyrinth of DPC practices that allowed us to service an employer and giving them the same quality and the same benefit to their employees. So there was no disparate in terms of benefit and plan designs. Inside of the plan design, that was a whole nother creature, you know, in terms of steerage and financial direction on how to help patients. But more importantly, starting to really understand the ROI that's attached to primary care when it's done extraordinarily well, extraordinarily autonomously. And my whole mission when I started the company in 2014 was I wanted to change an industry. I was really not interested in changing the practice for myself. I knew from the beginning, for me, I would never practice in my practice, in all fairness. So I worked 2 and 3 jobs, paid for a physician to come into the practice and built the company. I don't think I took a paycheck out of the company for like the first 4 years. It was really just me just working to pay other people's bills and putting the money back into the company. Well, I went through partners, I bought partners out, the company almost went bankrupt. Like there's a really nasty history to the organization. But fast forward to 2022, we were at a position where we said we can't continue to be this small. So we had tens of thousands of patients at that point. A very successful direct primary care practice, and we were pure. I never did hybrid anything. It was always direct primary care. And it just got to the point that if you're going to change healthcare, you have to do it in a much bigger way. And so we started looking at the opportunity. Are there partners out there that would be willing to acquire us and give us a platform to expand this model on a national scale? Because what we had a problem with was scalability. If you've seen one DPC practice, you've seen one DPC practice, and that's the problem, in all fairness. I always said, if we can just call every practice out there Acme and just have a foundation of what DPC is, we could change an industry really quickly. So when I went through this process, there was about 24 companies that wanted to acquire us, and we cherry-picked One Medical out of that. And the reason we cherry-picked One Medical is because clinically we were so far aligned in terms of how we take care of patients, how we see patients, how we spend time and quality with patients. And what they had was a footprint, 200 and something locations across the country. Rashika was a good friend. He just acquired Iora. He was the first person I called. One Medical was looking at us, and it became this opportunity to say, hey, One Medical is a really significant primary care practice. That's all they do. They don't own hospital systems. All they do is primary care. Fast forward, we got acquired by One Medical. We're on a summer vacation. We come back home from summer break and we land in Denver. And there must have been 1,000 text messages telling me I work for Jeff Bezos now. I had no idea this acquisition was happening inside of Amazon to One Medical. But nonetheless, the partnership, obviously Amazon acquired One Medical in that. And in doing so, it created a massive opportunity and a massive platform for direct primary care, in my opinion. So you can either look at it and say, well, they're not direct primary care, or they're not doing direct primary care, or maybe they want to change direct primary care. And what I can tell you is there's probably, it couldn't be further from the truth in terms of what they want to do in terms of direct primary care. Right now, I'm the head of direct primary care strategy and innovation for One Medical / Amazon. And my role in the organization is to put the division of direct primary care on a track moving forward that allows them to have opportunities in direct primary care space that companies like mine would never have access to. So companies like Boeing, companies like Amazon. As big as I would never have access to these organizations, ever. We're just not on equal playing fields to have that type of conversation. Although I would argue we probably do more sophisticated things inside of plan designs with consultants and self-funded companies than most large jumbo employers do. Because they're maybe a little bit more restricted in how quickly they can do things or how fast they can get to a decision, which allows the companies in the 50, 100, 250, 2,000 to make decisions in a maybe quicker way that allows us to expand direct primary care across the country. So what we're doing today is really setting a foundation inside of the organization to understand, one, what is direct primary care? How is that different from your core of what you've been selling, which is this hybrid model of direct primary care and fee-for-service? And I always put things on spectrums. There's a continuum. Fee-for-service is over here. It's always been over here. Direct primary care sits way over on the end of the spectrum. And we was a bunch of cowboys at first, right? I mean, Dr. Bliss was one of the first persons I talked to after I started my practice. And it's this spectrum that creates the utopia for DPC over here, this fee-for-service thing that has to change. And One Medical really kind of fell right in the middle. It was like, here's a little bit of a PM structure, and then we're going to bill your insurance. That doesn't really create a massive ROI, in all fairness. It doesn't create this utopia of how do you manage a patient. I always think of people in a bubble. DPC, our job is to keep a patient in the bubble as long as humanly possible. So you put things in that bubble, things like Rubicon or things like specialty consultants or your peers, and everything that we can do to maintain that patient member inside of the bubble creates one fewer transactions. And if our whole goal in DPC is to eliminate as many fee-for-service transactions as humanly possible, because when you do that, you generate an ROI that translates into stickiness, it translates into cost savings, and when we're an added cost to an employer, we have to justify why we exist. So people writing us, $1 million to $3 million checks, they want to know that it's better than just a feel-good story. So when you can show them, hey, we're probably managing your second largest P&L item on your budget, and we're giving you a 20 to 30% return on that P&L, now it's time to invest in primary care. And so my job inside of One Medical is really to get them to understand the value proposition that direct primary care truly has. How do you go from the continuum, from where they're sitting in the middle, and show them an opportunity that there's this other thing called direct primary care with a different payment model, a different arrangement model, a different practice model that allows us to be better partners for the employers, especially in a self-funded space. Our job, I would argue, I've always had an issue with the term advanced primary care because I don't think it really quantifies what advanced primary care should be. Nowhere in that definition do they mention financial, anything. It's always access and quality and provider satisfaction type stuff. But as physicians, I think we have a responsibility to do no harm to a patient. That's always been looked at from a clinical standpoint. But I think it's transitioned into a financial standpoint over the last 10 or 15 years. We have a fiduciary responsibility to do no harm. Medical bankruptcy is the #1 cause of bankruptcy in this country, and we're the cause of it by sending people into areas of care that maybe could have been avoided or maybe could have been navigated a little bit differently. So my job, once again, inside of Amazon and One Medical, is to really educate them in this process, this thing called direct primary care. One, not to bastardize it in full transparency. I hate saying it that way, but it's really important that we don't change the core foundation of what direct primary care is. Two, how do we expand it into a population of employers that most of us would never have access to? And how do we do it in a way that creates a path forward for all the little DPCs that want to come up today and in the future? Because the easier we make this, the more successful we are, the more likelihood that there's going to be more physicians to come into the practice. I think one of the greatest things I can do personally today, and the things that I get joy out of, is hearing young physicians coming into primary care. When I came into primary care, it was very frowned upon. We were on a pendulum of specialists. And primary care, you knew you were going to get paid the least. Well, pediatricians got paid a little bit less than we did. But we weren't going into for the money. It was because we had a calling into primary care. So recruiting new physicians into primary care, this is the path forward. The path forward is not say, well, we're seeing 25 patients today, and next year you're probably going to have to see 26 or 27, because that isn't an argument that will not end until you eliminate all physicians, because there's a breaking point. What if you can go back to physicians and say, listen, you're going to make more than what you were making in fee-for-service. You're going to see 10 patients a day, 12 patients at most, compared to your 25 or 30. You're going to have quality of life. You're going to have work-life balance. There is so much value in primary care that gets dismissed because of the fee-for-service world that we've lived in for such a long period of time. So the job is having partners like Amazon, having partners like One Medical, having partners like Boeing, in order to push this thing forward, to prove the model at a scale that we could never do on our own, is an incredible opportunity. And I think it's something that we just need to continue to push forward. It may look a little different from when I started my practice as a, primary care physician of a doctor of one, trying to just pay an electric bill, to taking care of a company that has 500,000 lives, 2 million lives. It may look a little different, but the foundation of what direct primary care is the same, from the independent practice to the One Medical practice to this Amazon Boeing transition. It's just gonna look a little bit different, and that's okay. So that's what I'm doing.
Yeah, I want to say one more thing. It's very interesting to hear because I've been wondering what you were going to say for a long time. It's been a long time since we talked. When people are talking about, well, what about $2 billion over 10 years? And one of the answers to that is, where are the primary care doctors going to come from? And how are you going to bring them if you're not willing to spend $2 trillion over 10 years to show them a kind of practice that will actually work, that they will enjoy, that will be meaningful, that will not turn them into lunatics and people who want to run for the hills when they're told it's time to go to work in the morning. So the idea that it's time for us to fix the shortage of primary care, and one of the ways to do it is not just throw money at it, give those people a playing field to play on in which they can do meaningful work and make a living. That's it. And it sounds like you guys are looking at that.
Yeah, it's you know,
that's a fun territory to think about.
It's a fun territory. I think you know, as a physician, being able to employ other physicians was an incredible opportunity. I will never forget this. It was, I think, the second work anniversary that we had. I think I had maybe like 6 providers at that point. The husband of the provider came to me and he started crying we were eating dinner. And he goes, I just want to thank you for giving me my wife back. I'm like, what do you mean? Because she's not been part of the family for the last 10 years. She comes home, she does church, she doesn't know the kids. She's like, she is a family practice mom. And he was just over the top with the idea that this model has given her family back, you know? And so it's an amazing thing to witness when you see a physician go from being burnt out to being excited again, to being energetic again, to wanting to read again. Like, it is a different human being. And so I think, you know, to your point, Dr. Bliss, you have to show a different opportunity to these young med students and these young residents that you're not the redheaded stepchild anymore in family practice. You can have quality of life, you can make a lot of money in primary care, and you can have a quality of life that is far beyond anything that you can imagine compared to the fee-for-service rotations that are about to go on. And that's what we have to do. AAFP has been part of that as well.
Any other thoughts, questions for Mark on this?
I've got a question. First, Michelle. So I imagine it's your second leading expense item, insurance. And
Comp and benefits, yeah.
Yes, but teasing out the comp.
Yeah.
And so, I don't know if you guys can share that number or in the ballpark, but I'm just curious to know what kind of numbers of potential savings that if we're able to show, Mark, which is my next question, is, you know, the ROI. And, you know, if it is 15 to 20%, you know, I mean, these have to be big numbers. And secondly, have you guys done that? I mean, I have to imagine your actuarial people have calculated these numbers.
Yeah, so I can tell you, you know, we spend $2.4 billion annually on health and health administration. That's everything. So it's a large expenditure. The CFO does not want to see that go up. He wants to see that go down. And although, you know, I think there's also this recognition, because we did the study, because we've been on this long journey, that there's this understanding that you do have to invest in prevention to see the ROI. In the study, and widely, you know, it's been around since 2009, you know, we saw 20% savings over 2 years. These were patients with 1, maybe 2 chronic conditions. They were folks that, you know, had a lot of improvement, obviously, that needed to happen. There was a lot of room there. We don't claim and think that we're going to get 20% savings everywhere. You can get a lot less than that. My colleague and the head of our health benefits, Jeff White, was supposed to be here this week. He could probably answer your question a lot more eloquently than I can. But yeah, you know, we don't have numbers. We haven't published numbers in terms of what we've seen, but the return is there. Yes, the numbers matter, but also the member experience and the anecdotes of what people tell their colleagues. You know, they say they think about healthcare differently. They, you know, don't hesitate to pick up their phone and text their doctor and their practice, and that's a good thing. And so that also comes into play.
Yeah, and not to belabor the point, but I mean, I'm sure all this data is there to just go in and look to see, even if it's 10% or 5%, you know, that's a pretty big number. You know, it's going to cover somebody's bones. And
when $4 trillion is the underlying number that you're talking about altering.
Yeah,
when it's the national costs.
Right.
Yeah.
Yeah, and then with employee retention, and you know, you can tease out, you know, the DPC people versus the other insurance people, you know, how many more employees are retained, or does it work as a recruiting tool?
Yeah, we like happy employees. So happy employees are productive employees. The productivity we found in that study was a 56% increase. So
But I would imagine there's
that's a lot.
I wish I had that to walk around the talk about, but I guess we do.
Probably a bit of an aging workforce.
We do. We have a older population than the national average. We've trended historically typically male than female, more male, but so more cardiac, more musculoskeletal, given the work we do. But the workforce is changing. We have a lot of 30-year employees, and that plays into the ROI and the investments up front and the willingness, knowing that we're gonna have those employees for a long time.
It would be nice to see the age distribution of savings, because I can tell you, we have 2,000 people, and we save a lot more money for people that are 80 plus, you know, or 65 plus versus, you know, 50 under. Just convincing someone that they probably don't need that back surgery, or they don't need the hip surgery right away, or, you know, whatever it is. A lot of times we can get better.
Yeah.
Just
Yeah.
to do it.
Continues.
So you mentioned the 2.4 billion annual expenditure. Is that 100% absorbed by Boeing, or is that somehow passed on?
Boeing's outlay every year.
Are the employees contributing anything?
Yes. Yeah. Now, but for the most part, with our high deductible health plan, those who make $80,000 or less have a $0 premium contribution, and then it goes up, you know, tiered up from there. But yeah, everybody else contributes.
And do you offer an HSA?
Yeah, our high deductible is an HSA. We're at definition. So what is it this year? $1,650 and $3,300 deductible. Boeing puts in a little less than half into the HSA as a contribution. It's a 90-10 plan, 85-15 plan. It's very high quality plan. And then DPC, you know, for our folks in Arizona that have it now, it's integrated into the health plan. It's just another option.
Have you done any studies just on the DPC in Arizona? The impact?
We have, I think, with the transition with One Medical in the last couple of years, 2022, we haven't, you know, really had a lot of data, you know, long enough to put out. But I know Jeff and his team are trying to figure out what we do have, do an actuarial study and and be able to put something out, hopefully soon.
Well, we've been talking a lot about data and Maryal and Janine, if you don't mind, I think we're going to jump one ahead on the agenda and introduce Fritz Busch to go a little bit deeper into this because I was really pleased to meet Fritz and begin working with him, I think in 2019 on the 2020 Milliman study. And that's been the one piece of data that we've been able to show. And it was interesting because here it is 10 years later, reiterated the finding essentially that there was a possibility, adjusted in the study for up to 20% savings. And we've seen other pieces of data, the data that Erica put together for Q-Liance showed similar kinds of things. So we're gonna go out of order a little bit and we're gonna talk about the Cali DPC effort next. But since we've already jumped into the data discussion, which I'm really happy to hear, I thought I would let Fritz talk a little bit about, well, if you want to address the older data and what we're trying to accomplish now.
Yeah, I got a little bit on there, right?
Yeah,
I'm actually not ready. I was hoping for more time.
Sorry. I just thought it was a good segue.
No, it is actually. There's been a lot of good comments here, so I think it is a good segue. I'll try to make it short so that these guys can jump in here. But yeah, so first of all, thank you for having me here. And I appreciate being able to crash the DPC parties. I started doing that back in 2016 at the Indy conference. So if you were at that one and you saw some guy wandering around with, a tear coming down his eye because he didn't know what he was doing and nobody would talk to him, that was me. But the DPC community has been very gracious to the actuaries, and we do appreciate it because we do a lot of work for a lot of different clients. But we don't always get to do work for clients or do research on things that we really believe in. And so doing work in the DPC space, we don't get paid much for it. We do it on our own time, more or less. But and the reason we do that is because we do believe in it. But very quickly, by way of introduction, I've been at Milliman for 9 years. I was on the carrier side before that, so I was on the insurance side. So I've been around for 30 years now, and the more meetings I go to, the higher the odds are that I'm the oldest person in the room. So been around and seen a lot of different sides. Milliman works, and I do a lot of different work for a lot of different clients. And I want to give you one anecdote. I think it's to Mark's point here, to maybe several points. But we were doing some healthcare reform work for 1332 waivers. Maybe you've heard of those things. You get some, you put in a waiver, you get some money back from the states, get money back from the federal government, and then you can do certain things with this money. And one of the things that we were talking to one of our clients about is attracting more primary care physicians to their state. These were Western states. And so we got an opportunity to talk to them about, well, why don't you take some of that money and do a forgivable loan program to get primary care physicians to come into particularly your rural areas. And then we were able to tell them about direct primary care, that this is a very attractive model. We can tell you more about it. And this could, if you were trying to get someone out into rural New Mexico, I don't know if that's probably not a very attractive site maybe for starting a primary care practice. But if you can do it with a forgivable loan and do it on the DPC model, that's going to, to Mark's point about the benefits of DPC. So they were quite intrigued with that. So we work with employers, we work with state governments, and we have a lot of opportunity to kind of spread this message. If you don't know anything about Milliman, well, first of all, our first study is out on the DPCRx site. It's out right out in the front there. If you don't know that, I think everybody's aware of that. Milliman, if you don't know anything about Milliman, I'll just tell you this. We are known in the insurance industry of all life, health, everything. And we're really known for our independence and our objectivity is the main things that we're known for. So we are not known for advocating necessarily for this particular solution over that particular solution. And that is of great value to our clients and to you because it does come with this imprimatur of Milliman, and they know that this is not a firm that is going to just go out and put their stamp on, on anybody's widget. And so we would like to bring, our reputation for quality and objectivity back to a second study here. So let me tell you briefly about the first study. There it is. If you have not read it, I think just a couple of highlights here are relevant to some of the comments that have already been made. But that study showed it was actually a 20% raw savings and then a 13% overall cost of care reduction after adjustment for risk. So to Dr. Bliss's point, the criticism against direct primary care, as far as I've heard, and I have heard it, is that they just get all the healthy patients, right? It's just the reverse HMO argument, right? The HMO doctors used to say, well, you're paying me a capitation. Oh, my patients it was Lake Wobegon, right? Everybody cost more than average. And so they always said that they needed more capitation. Well, this is kind of in reverse, where the criticism is, well, you're getting better results because you have all the healthier patients, right? Well, maybe, but maybe not. And either way, it doesn't matter to us because we risk adjust it, right? And we use statistical matching to try to make sure, that we're comparing apples to apples, right? So we try to make this thing as airtight as possible, right? So there's no way that somebody can come back and make this argument that they said. The study also showed a statistically credible reduction in, this won't surprise anybody, in emergency room visits, right? The access alone is enough to explain that. We did not have credible data to get statistical results on, credible results on inpatient admits. We did see a lower, there was lower admits on the side of the DPC. Wasn't credible though, so we really couldn't make a conclusion on that. And then we wanted to look at specialist data, but the data quality was not such that we could do that. So needless to say, we want to refresh this study. The study that came out is now 4 years old. There's been a few changes in the last 4 years in healthcare, right? So it is getting a little stale. So we'd like to do it again. We would like to address some of the deficiencies in our last one, mainly some, small data set. The data set that we had was only 1,000 direct primary care lives. We have another 1,000 non-direct primary care lives. So we had a bit of a, control experiment group going. And so that's what we did that on. It was just one provider in one state. So it was relatively small, big enough to warrant the study. But again, some of these things, when you only have 50 admits, well, you can't do really anything statistically credible out of that. So we'd like to solve for that problem and get a lot more lives than what we have. So right now we're on track to get over 10,000 lives, which DPC lives. And so we'll do a slightly different type of study this time. The long-term goal that we want to do is really do this annually, is what we would like to do. We think that once we set up the infrastructure and we get data contributors that can contribute on a regular basis, we can use this report as, kind of we worked with AFP on it. We worked with the Society of Actuaries. It can be kind of a flagship type report, we hope, and can be used by, constituents, the doctors, the lobbyists and whatever, so that you can have something that you can hand to an employer or to, whatever. They can say, look, this is a high quality study that is done, and it's recent. It's as recent as last year. So that's really the goal. As far as this study goes, we are trying to stay on track for a Q1 2025 publishing date. Currently, we're in the middle of the data collection process. That's what I'm going to talk to you about next, about how you can help. So our timeline is really dependent heavily on getting the data, getting it scrubbed. Data often is very messy because nobody gives it to you in the same way. So a lot of this is very, very dependent on the data. We do have commitments for about 10,000 lives right now. And Mark, I think your group is one of them. So I'll wrap up by saying this. How can you help? Well, the reason that we're here is to make you aware of this. If you, if you're in the room and haven't heard of this, you want to participate, please let me know. Or let other people know. We have quite a few of the larger DPC providers that we've talked to. Some are, like I said, willing to participate, some have declined. and that's fine. But let me tell you a little bit about what might happen if you do decide to participate. I'll make this very quick. We have a process now that's pretty streamlined. So if you're worried about, undue, amounts of work, we have this down reasonably well. We like to work with the DPC provider, the TPA, and the employer. Sorry, couldn't think of it. So those three we like to get together because we want the DPC provider to be really behind this, right, and really advocate for the TPA working with us and giving us the data, and then the employer basically giving us the permission to use their data. So we like to set up a meeting with the three of those three parties. After that, we will work directly with the TPA and the employer, and then ultimately just the TPA to get the data, scrub it, add all of our fun little tools to it that help us to do the analysis. And then we do all that and we collect the data, we store it securely. It's all de-identified, there's no HIPAA issues, okay? So you don't have to worry about any of that. From an employer's perspective, it's all, we're gonna design the study so that no employer is identifiable either. So it will be aggregated in that sense as well. We need to be working with larger employers, mid to large size, and the reason is it's just too much work to do it for 30 employees. So we need to stay upwards of over 100 employees. Because it's too much work for two guys to do that. So again, if you're interested in that, we would love to get that number, and I think the study itself will gain, the more members we have, the more value it's going to be, and the more less permeable it will be to criticism as well. So I'm going to pause and see if there's any questions on that.
One of the nice things that I love about this data set is, when we go up and use it, it's like, well, you don't have to believe us. This is the actuaries talking, right? So this is a very, very credible source, and everybody we've been able to share this study with on the Hill has looked at it very closely. Fritz will be joining us on some of our visits tomorrow, and I think, has a lot to offer to bring to the table because, there is a lot of soft, fun, excitement, patient encounter data that's out there that's wonderful. This is hard data. And it's hard data that says employers are saving money, employers are figuring out a way to do this that provides a value equation that could be savings, it could be people that come to work on time, it could be people that stay with an employer longer. These are all very tangible data points that are critically important. And again, I want to thank AFP for joining us in helping to rally the troops to try to get involved in this. AFP does an annual survey that usually touches DPC as well. We're trying to coordinate this as much as we possibly can. I guess I would have a question. If you are a smaller DPC and working with some smaller employers, are there ways where you can participate and help as well? I know last time we did a lot of benchmarking, asking people questions about what the practices look like that contributed to the study as well. But I'd love this not to just be large employers.
Yeah, I get it.
If it's possible, I understand the workload there, but is there a way people can help?
I think there is one of the things we want to do with this study is, once we get the results and we put all the numbers and that's going to speak to the actuaries and the other numbers related to people, the finance type of people. But what we really want to do then is take these numbers and bring them to, possibly doctors, DPC docs in this room and others and say, put life around those numbers, right? Talk about, okay, well, the one we mentioned already was ER visits, right? Well, it was a 50% reduction. Well, tell us why that is. Well, it's easy to say, well, it's access. They don't have to go there anymore. But there's more to it than that. And then there's other things that could show up in the data, specialist visits, admits, things like this. And one of the things that's great about going to the HIM conferences is I get to talk to doctors. And they do tell these great stories about, who's the fella down in Kansas? Vance. He told me some great stories, really entertaining stories, but really enlightening stories about, how his practice has made a difference in the lives of people. And we really want to marry up the clinical data with the real life color, right, that goes with it. And to do that, we need to be, we'll need to be talking to you all. And that's not size dependent whatsoever. But from a data perspective, we're probably just not to the point yet where we have it built out efficiently that we can, we need to try to really get it down to maybe 10 contributors that have a decent amount of members. It's,
generally the businesses are self-insured, have TPAs, they have claims data. I mean, those are all the things you need. And so,
I would always tell you that it's not just, the thing that we get wrapped up on is ROIs so much. And the Milliman study has been great to just point to a direction, but it really didn't do anything other than substantiate the fact that we do a really good job with direct primary care in spending money. I think the thing that really gets lost in this is understanding that not all employers are trying to solve an ROI problem. They're trying to solve retention problems or recruitment problems. School districts, for us, we have dozens of school districts. They all pay the same. They just pilfer teachers from one district to the other by benefits. And so if this district has a better package or a better benefit, and that doesn't mean just a lower deductible. We have zero deductible. So it's how is the experience that the employee feels that the employer values them from a standpoint that doesn't really translate into an ROI. It's been something that's been challenging, just wrapping a number on a product. We've done tons of data through this as well. It's not always just the ROI conversation that's really important. It's understanding what problem are they trying to solve, because every employer is a little bit different. And I think that's the value that DPC brings to the table, is you can be really flexible in solving those challenges and those problems. But the Milliman study's been very,
Which sounds great. Like, it sounds like you're collecting some of the stories and the heartfelt and the changed lives, which I think is going to be extremely impactful. Because to your point, depends on the employer you're talking to.
Right.
We've had numerous discussions where what's your ultimate goal? Like you said, is it recruitment, retention, or is it plan savings? And then you go down that. You have two different paths most of the time when you're talking about this direct primary care product.
The interesting part too, Fritz, is I don't know if you know. So we're doing a pilot with Kaiser right now. So Kaiser is actually paying me to take care of their patients in primary care. And they're paying me a direct primary care fee, right? So when we ask, and I didn't answer the question, maybe I'd clarify it. One Medical is doing direct primary care in a true quintessential direct primary care platform. There is a PM structure or a PEPM structure. It is DPC to the core. We just want to position ourselves to roll out national products in 2025 that has huge impacts on the industry. But Kaiser, fully insured, right? So now Kaiser is my client, right? It's not the school district that takes Kaiser as the benefit plan. It's Kaiser's my client, because if I save $1, Kaiser's the beneficiary of that $1. So it's getting upstream to understand that, like, these really large employer groups, and Kaiser as one of them, sees the value in direct primary care, but they're having a hard time quantifying it because no one's got the data. Fritz has been extraordinarily easy to work with. Like, here's a client, boom, hand them over.
For an actuary.
Yeah.
Right.
and get out of the way. So, it's been very beneficial. So we do need the map and the help, but the story is what's missing behind these numbers.
Someone mentioned.
So there's also, are you quantifying patient experience and health improvement, population health improvement, or are you just looking at financial savings? Because you can't forget the AAA, right? We have to be continuing to look at those other pieces, because that's, if you can quantify it in the same way you're quantifying the financial piece, then, that's really justifying our existence in all those levels that you mentioned.
I think we don't, but I want to say that AFP, did we do that? Talk about NPS in the first one? I just don't recall now.
We asked the physicians if they felt their patients
Yeah.
were happier. So it was all about perception. So you have to take that with a grain of salt. That wasn't actual.
Yeah, no, so we did nothing on that. I mean, I think that can easily be done by someone other than us that's really just surveying and everything. I'm not saying it's not important, but to answer your question directly, we are focusing purely on the ROI.
Right.
We spend a fair amount of time, talking about the qualitative aspects of DPC and some of the, things like that. But somebody made a comment about the comorbid conditions, the comorbidities. And one of the things I tell employers that have come to us and asked us about this is I say, well, if you have a sharp knife, you want something to cut, right? You want to be able to cut a lot of things with that knife. If you have a population of only 25-year-old tech kids, whatever, DPC may not save you very much money at all, at least initially, because there's really no care to manage there. It might prevent care, and that prevention is obviously really important. But my answer to them is always that I believe that DPC is actually clearly more effective on these patients that are 5 times the cost of the healthy. It's this 80-20 thing. Well, now it's probably more like 70-30, right? Where the 30% of people with the high cost, honestly, those are the people you want, because that is going to make, it's going to make our job easy too, because I believe you will easily prove savings on that. You can't do that on somebody who's 25. So again, going back to this risk thing, if you have any way of influencing that, you would want to influence towards, hey, give me your diabetics, give me your COPD.
It's one of the things that we've always led in. We go to these consultants and brokers, and we don't want a client that's running at a loss ratio of 70%.
Mm-hmm.
We just don't want them, because we're not, if we're having an ROI conversation. So we want the sickest population that is out there. So if you're running at 120, 130 loss ratio, we want that client, because we'll show impact really, really quickly. We have tens of thousands of NPS scoring from our surveys. I don't know if it's something we can layer into the Milliman study in terms of looking at NPS scores for satisfaction from the patient, not the physician, that might help.
Well, I think we are onto something, because I know we've talked about Net Promoter Scores before with the Erica collected and others. There are other patient satisfaction measures. We've also worked pretty closely with a great socio-anthropologist at VCU on a new set of measures to really measure what patient experience is about. And I think this is a great offline conversation to have about working together on that data, because this is another place I think the smaller DPCs can provide some value, because I think a lot of DPCs have their Net Promoter Scores that they use to try to improve value to small employers, and they mean a lot. So I'd love to take that conversation offline and figure out how we can work on that together, even if it's an adjunct to the Milliman study. But I do think it tells a lot of the story. I think you can extrapolate a lot of this data about the patient experience from the reduction of visits, from the reduction of hospitalizations. When you think about what CMS is looking for today about a way to measure value, it's reduction of hospitalizations. That's candidly all they really care about right now. So I think we need to care about more than that, but I think the data does tell part of that story.
Yeah, and I'd also say that in the world of quadruple aim, we should be also asking the physicians what their lives are like. We learned a lot when CMMI got involved with, and they started talking to doctors in fee-for-service and doctors in DPC. The difference in terms of their mood and their general feeling about the world was dramatically different.
And we do
They
have
were
access
the
to that.
angriest. They were angry, and we were pretty happy. And it was big and obvious. So that's another place to look. So if we really want to
understand this. You don't have to do everything we want to do, but I think that we as a group should be looking at it, because that's an easily measurable thing amongst physicians and also amongst their clan of patients.
We do ask that in our survey. So our survey is out right now. It's more of a DPC practice profile survey, asking the physicians like, when did you open? What is your patient panel size? Do you work with employers? What do they ask? Really collecting that characteristic data that Natalie can then use in these types of conversations. But we do ask them, what is your level of burnout or well-being? And then we also send the same survey to our fee-for-service. Like the first question is, are you in DPC or are you not? And if they say no, they get a set of questions that says, what is your patient panel? How happy are you? Those things, so we can then compare it to the ones that go down the further study for DPC and tell us about the practice. So,
Are you guys publishing any of that?
That is our goal this year, is to get it out there. The numbers honestly are a little low right now, so I think we're going to do some outreach to get more people on it, but the goal is to publish it this year. So
yeah, well, let's talk a little bit more about that too, just because the last time we did this, we were able to sort of come together to get people to, agree to take the survey essentially, and it'll be the same thing with Milliman as well. I do want to advance the ball on the agenda a little bit, because when we talk about DPC markets, the data is really important. I think potentially it's no secret one of the largest markets in the country is California. DPC is experiencing tremendous growth in California, and it's been interesting because we have a whole other like in most states we have some insurance law and the Board of Medicine that we need to take care of, but in California there's a whole other set of statutes that cover managed care organizations, which technically the state kind of looks at DPC as kind of that. So and I wanted to put a shout out to Maryal Conception too, because these awesome infographics that we had, which were horrible lobbyist written, completely white pieces of paper before she got her hands on them. Maryal really put all of the heart and soul into these infographics that we're using as our handouts on the Hill. So not only has she become an in-kind member of the Direct Primary Care Coalition staff, in the PR graphics department, but I've been really thrilled to get to know the folks in California. They have launched their own branch, like we did in Massachusetts a number of years ago, of the DPC coalition in California to maybe take on the bear and wrestle some of the issues that are in California. So I'd like Maryal and Janine to talk a little bit about what's going on out there.
So I just want to put a shout out to Emily Scott, who was at Halcyon DPC. She and James, her husband, opened the same year as Janine, and so they're going on their 9th year. But Emily had said at one of our meetings that Jay told her, so in 9 years ago almost, DPC can't happen in California. And so we all laughed at that because here we are, here we are. But one of the things that I just love to point out on my podcast over and over and over again is that as the data is so important because it literally gives us ground to stand on, what really sticks and what you brought up is telling our stories. And so in California, the reason why DPC has grown is because residents, medical students are asking us, so what is it that you do? Because you seem to be a happy doctor when you're seeing your patients in the outpatient setting, in the clinic. Or my residency director told me that I'm the kind of doctor who likes to spend time with my patients. How do I do that? Because they directed me to you, and you don't take insurance. So advocacy absolutely is a piece. To have the data allows us to advocate. However, education is important. And most importantly, we can't do DPC if it's not protected. And so DPC is protected in 33 states right now. We are hoping to move the ground even more to allow DPC to be protected in the state of California. So a few months ago, we got together and we created our Cali DPC coalition. And it is, maybe 7 of us that are talking with Jay on a regular basis to see how we can poke the bear strategically so that we are representing what we're doing, so that we are especially presenting ourselves as that we're not insurance. So,
this conversation started after we attended the California Academy of Family Physicians combined residency fair and clinical forum, where we thought, this is the place where we're going to get a shot at exposing residents and medical students to the model of care. So we kind of pulled it together and had our own little table and got actually some really interesting and fun connections. But then we started to think it's maybe time, because clearly California it's a large state and has a lot of moving parts. And poking the bear, as we've been saying for I think the last decade, was sort of a ominous process. And we do think, though, that using both, as Mark said, the educational approach, trying to get the message out, especially to younger physicians, and then working actually with the CAFP to start. We finally put together a resolution to help with this issue over the HSA and the insurance definition, so that we can say the Academy has been helpful with this. We would like California to come forward and be helpful with that. We'll be all meeting in Sacramento in April to work on that resolution to see sort of how the rest of the organization is receptive to that. We've restarted our website. We're working on, I think Maryal's finally gotten into one of the committees of the CAFP. So she'll be working on continuing education, professional development. But we've sort of started this movement to try to get our message forward and to educate the next generation, basically, of physicians coming through medical schools and residency programs, as we can do that work for the 7 of us that have started this. So.
What is the chapter, like our specific chapter, what is their stance on? Are they being supportive right now, or are you still in the influential stage?
We're still very early.
Yeah, okay.
Yeah.
What exists in California right now is that there, in 2017, was an adoption of the policy put forth by the AFP in 2013 to say, like, we support this.
Yes.
However, there's still no clarification on what DPC is. Also, there's no presence of independent physicians on the CAFP board whatsoever. And we are also breaking into that with all of us applying to be on every single committee that was present. And so we are, here, one, to educate, what we're doing, the people in California, but also to educate, like, if anybody out there is listening, this is how you can potentially, if you're not in a DPC protected state, start getting your foot in the door.
Yeah, and I think it's really important to note that there's a large cadre of DPC practices in California, and I think essentially we've had regulators that have just not been knocking on anybody's door here, but should they choose to at some point, it would be much better to have, rather than just sort of legal precedent, an actual statute that was clear. And today I would say it's unclear. It is unclear whether or not you are an HMO. Anybody who looks at you knows you are not an HMO. So this clarification becomes very important. And I think what we found is the way to do this is to get involved in organized medicine in a way that really helps. And I know a lot of people have really decided in the DPC movement and said, well, maybe that's not for us, that's for somebody else. But if your voice isn't there, you're not going to get heard. So I'm really excited to see folks in California, running for committee slots, running for the board, and submitting a resolution that I think is very, very well thought out that would take the California policy to the next step. And that next step is let's do a survey and see where the liabilities in the law are and what in fact we need to do. And maybe we just need to get an opinion from a regulator rather than to go in and pass a law. So let's take a look at that before we jump in head first. So I really love the process that's going on there. It's been a pleasure to work with you all on that.
And I think that, just going back to the data on ROI, the data, of independent physicians and where the data can be very helpful in California. I just foresee this when we're talking to physicians who have done DPC or are transitioning to DPC. I think it would be very helpful because, a lot of doctors, especially if they come for fee-for-service, are PTSD'd over, what codes, how many codes did I get of XYZ? But I think that strategically, like something like the Larry Green study or something that would be very helpful for us to all be collectively aware about, to be able to track our data without tracking codes. I think that thinking along those lines would be very powerful to present the physician story and not just focusing on the ROI or other pieces of data. But we haven't gotten there yet.
And we have a great vehicle to talk about this and my DPC story too, which is really exciting.
It's the top podcast in the nation about direct primary care, and technically it is top 0.15% in global reach of all podcasts on the globe, which is incredible because that's how many people are wanting to know about DPC and what we're doing. The niche of people who are listening, it's over 30,000 hours of listening to the doctors sharing their stories. So that matters. That absolutely matters.
Well, this has been great.
Yeah.
Can I point out one thing real quick? Just to update on it. So, we definitely have switched over to more employer-based direct primary care, which is great. I think that's potential for growth is there. There's some of us that are still direct to consumer almost exclusively, not by choice, but by happenstance. But I can tell you the one thing that it's really important to know if you're new and starting and building a practice, which is it's a bit counterintuitive, is that the more you see them, the more likely you are to keep them. So it's like streaming service or whatnot, the value of keeping the patients, we have a high churn, people moving, people dying, but there's very few people are leaving for another primary care practice.
There is no access.
There is no access, but still they do if we don't see them once a year or we don't find some way to touch them other than, electronic, email, all that other stuff doesn't go far. But again, it goes to these more complicated patients that have more need. Those are the people that stick and stay.
Right. We, in our area, there's not a single primary care office open. We have 3 large, big groups that are hemorrhaging physicians. And so it's not only primary care that we don't have vascular surgery, we don't have enough neurosurgeons. It's a mess out there. We have, many of us, we don't take any employers in our office. There's a 100-patient wait list. People are bailing out of these large groups because they're being put in these care management teams that is never the same provider. And they are not being cared for. The majority of people coming even to our private practice are Medicare patients. In my practice alone is 45% Medicare.
Mine's 52% Medicare.
Yeah, and I'm still doing my hospital work, which is the other part that they actually appreciate because we can maintain the bubble in the hospital.
And if the data extrapolates and these patients are paying you out of pocket to see you, and, in Medicare, which they have to because Medicare, we know won't pay you, you're potentially saving Medicare 20% of the total cost of their care. And we can extrapolate the data we've seen over the last 10 years. And this is a point we make to CMS all the time. They're aware of it and they get it, they understand it. They might not know how to execute on it quite yet.
But I do think this is why it's become the opportunity in California, because if we're burning out residents and residencies before they're being pushed in their own clinics. Many of them are moving into hospitalist positions because there's fewer volume than actually being a family medicine physician in the community. And so, these rural family medicine residency programs are like scratching their heads about, well, why are they all going into hospital medicine? They still can't figure it out. And so it's a prime opportunity to start moving, to bring the young generation in, to say, no, I know you're burnt out in that, and I know they're forcing you to see 30 patients in your rotations, but we do it differently. And so what we really do need to focus on getting that group of people to see the model, to understand how it works. And that's the group that's going to pull us forward in our next sort of phase of growth for this movement.
And when we were at the POP summit, we had the most interest from the younger people. Even at our, statewide CFP advocacy meeting, the doctors who have been in fee-for-service, you'll hear things that are just impossible, like, oh, I know the way to change the policy is you outlive everybody else. Or like, well, I love family medicine, but I'm much happier doing just diabetology because I don't have to do everything and I can go home and see my kids. Like literally, these are statements the doctor said to me. And it's so sad. And so when you see, and I'm so proud of the younger physicians and residents for recognizing there's a difference in what they went to medical school for and what they're actually doing in healthcare teams that are where the physician is not the leader. It's very, I'm very proud of them for recognizing these things early, but again, we have to have a ground where they're protected so that they can do DPC going forward.
We can really collaborate, because I'm running the resident and medical student, sorry, I'll stay right behind you. I'm running the resident and medical student department for the Direct Primary Care Alliance right now, and I can push you a bunch of resources that we've developed just over the past few months. So we've got a social media page to recruit residents and medical students, and then we're pushing out newsletters, and then we also set up a speaking circuit. We go and talk to medical schools and mostly family medicine interest groups about DPC, and then also a curriculum for them to go do rotation. So they should just grab off the shelf and it can go to any DPC clinic for them to be able to utilize that to set up, hand their program director and say, I've got this curriculum, I've signed it, the doc has signed it, it's all good to go. And pretty much once that paper's good, as long as the paperwork's fine, they can go do those types of rotations. So I'd love to work together on that. And it's challenging because you kind of get stonewalled by some of these residencies because they all want a single payer system. It's kind of the mindset in there.
Yeah, it's interesting because I find with residency programs and residency program directors, the residency program directors, as much as they're in a fee-for-service model, they listen to their residents when they're asking for DPC to be presented at didactics. So we're talking all the time to residencies already. We have seen residents choose DPC because they heard us talk for an hour. So, we are definitely making sure that the voice of the independent physician is not forgotten. And it is what is inspiring, as we all were inspired, like Dr. Bliss, Janine was the one who inspired me. I didn't really know what DPC was, and here we are, right?
So, just on the residency point, I'm curious from a messaging standpoint. I think we all get the benefits of DPC, right? But what are you communicating to them from an economics perspective? Is that, hey, you're basically going to make double versus if you go into primary care, or how are you
It's
handling
so
that?
away from the economic part of it anymore. I mean,
Sorry?
it's so removed from that anymore that it's a matter of lifestyle and doing the work that you were committed to do when you started the pathway.
That's the biggest piece, I think, is I take a lot of residents and, or med students, and in third year, they come through and never are they, I'm doing family medicine, right? It's almost always, and this is from Thomas Jefferson, it's from reputable, med schools, and at the end of the rotation, the best thing I hear from them is like, wow, you can do all this in family medicine. And this was highlighted like 2 weeks ago. I got a consult report from a gynecologist, and at the bottom of it said, we recommend you see a primary care physician so they can help coordinate your specialists. Literally there, black and white. I'm like, that's not what I do, right? I think that's part of the identity problem of family medicine right now. We can change that by exposing them to the coolness of family medicine.
Well, yeah, I mean, they're used to these large groups where you're the bottom person, you check the box, and if they're true, they go.
That was specifically in our resolution, that we are supporting not only the DPC is not insurance, but we are allowing under the DPC model the practice of a physician to practice at the highest level of their training without being like a first-year resident in Santa Rosa told me this, referralologist.
The better, so it's definitely not the finances, because you can make a great deal of money as a garbage man. But, not a lot of people choose that life, even if the money is identical across the board. So the students are coming out and they're like, dermatology, ophthalmology, they're all so much easier and better lifestyle if that's what they're choosing.
Well, it's a matter of the need America has right now for more primary care physicians. It's beyond a shortage. I don't know what you would call it. It's a crisis, and so this is an answer, a way to move forward, and it's very appealing. I've taught Georgetown Med School students. I've taught residents on this. I've taught this to HR managers and brokers and TPA managers, and I have never had anybody pick it apart. I wouldn't say never, but very, very rarely do you have anybody pick it apart, except to figure out how to do it, or maybe how to do it better. How can I do this? Or if you're going to visit on a hill tomorrow, how can I get this? Is the first question that you almost always get. This has been such an amazing discussion. We're not done. We're convening across the street at Bistro B for dinner, but before we break off, I hate to do this to Matt, to be the last guy before dinner, but we'll give you the floor a little bit more at dinner. But we do want to talk a little bit about the DPCRx program that we've been working with Lineal Health with Brad and Matt on finding an easier way to get prescribing and dispensing. And Matt has also been incredibly involved in helping us crack what's really the last nut in the country, which is Texas, where dispensing is completely illegal at this point. So Matt, take it away in a few words, and we'll adjourn for our dinner.
Being brief is tough for me, but I'm between everybody's stomach and dinner, so I have no choice. Fritz had a number that was really interesting in his slide, which is 57% of DPCs dispense. I'm gonna throw out a couple other numbers. So when I started 8 years ago in the healthcare industry, there were 75,000 pharmacies in our network. Now there's 72,000. IQVIA is estimating that 1,080 pharmacies are gonna close this year. So I love going to DPC events because I live in a equally dysfunctional little niche in healthcare, which is pharmacy and pharmaceuticals. And y'all are unfortunately involved in that too. So the problem of a patient being able to follow the doctor's orders is actually going to get worse this year. On top of that, there's mandatory minimum dispense fee laws. Arkansas passed one, West Virginia has one. There's a proposed one in Illinois that says that every claim filled at a pharmacy is going to cost an additional $10.49. And most of that's going to the patient. The PBMs aren't going to get hurt by this. So on-site dispensing is something that really helps the patient. You're absolved from those laws because it's not touching the PBM. And then you're solving the problem of the patient's able to follow the doctor's orders. Only about 60% of scripts are picked up nationwide. When you hand it to the patient, it's pretty much 100%. So what we enjoy doing and what we've been continuing to do is helping to innovate some new programs to help make medication dispensing easier for DPC practices. And as the world's changing around pharmacy and PBM transparency, and I can go on and on about that, we have that intel and that insight to show as you're selling to employers, what does NADAC pricing mean? How do we compare to that? How do we navigate those kind of worlds? So I won't go into all of the nuances on that, but grab me at dinner. Feel free to follow up with us at any time. One of the things that we've learned is, and I think Mark said it, if you've seen one DPC practice, you've seen one DPC practice. I'm going to rephrase this to if you've seen one patient panel, you've seen one patient panel. The most exciting thing that I have tonight, and this is the last thing I'm going to say, is that AS Meds has decided with Lineal Health that we're actually going to put some skin in the game. So we're going to help create a PMPM model that goes beyond just the cost plus transfer or whatever the current status quo is, to help you guys develop a way to make it very simple. You're able to get a panel of drugs that covers probably 60 to 80% of what your patients are going to see. We're going to put some skin in the game on the PMPM for it. And then that's going to be something that's really going to make things simpler, faster, more efficient. And then I lied. I have one more thing to say. The last thing I'm going to say is there's a critical point to that too, which is we're true believers in prepackaged medication. And you guys don't give yourself credit for the work you do handing medication out to the patient. The Association of Chain Drug Stores estimated costs $12.95 for a pharmacy to dispense a medication. None of y'all are in here to be pharmacists. Time it takes to dispense medication is time away from the patient, away from your patients. We understand that. So we want to create a solution and help you guys optimize your practices so you get more time with patients and cut down that overhead cost that's your time getting drugs in their hands. And then I'm done this time.
Lots of questions around this, I know. We'll have a great opportunity to talk about this at dinner, which is hosted by AS Meds and HINT jointly. We're so thankful for the live stream today. We want to make sure that these conversations are transparent. You're talking to your colleagues, you're talking to other people in the movement. You're talking to people who are trying to learn from this and really take the message forth. Couple of notes about tomorrow. We're not going to be back in this room. We're going to be up on the 8 a.m. sharp tomorrow morning. Suite 840, which is our offices here in the Hall of States. You'll need to check in a little bit more. Again, unfortunately, that card you got today, I thought it was going to work tomorrow, but I guess they don't trust you overnight. So you'll have to check back in and show some ID tomorrow morning when you check in. But we want to see you at 8 o'clock sharp. We'll talk a little bit about our business tomorrow. Most of you have some visits on the schedule. We'll do some pairings in the morning. It's going to be a little bit, as it always is, a little bit of organized chaos. And unfortunately, we don't have our great former staffer, Margaret Colopy, to help us with that anymore, because Margaret is in her second year in law school. And Margaret, who used to be our staffer at DPC, is coming to join us at dinner tonight. So, because she only worked during the pandemic and never had to meet any of you all, except on the phone or via email. So Margaret will be joining us, at least for cocktails and hopefully for dinner as well, too. So it's right across the street, across E Street from this building, 15 E Street, Bistro B. We'll see you there in a few minutes.
Jay, will you share contact information for everybody that's here?
Yeah, you bet.
Names and emails, that'd be wonderful.
And I just want to sign off by saying everyone on the live stream, thanks so much. And I'm just going to put a small plug in. Thanks for the shout outs for the Hint Summit this year. We're actually going to be announcing our Hint Summit this week. So the dates are going to be the 27th and 28th of September in Denver, Colorado. So we'd love to have you all there this year as well. Thank you. Thanks everyone on live stream. We're going to sign off now.
Yeah, I know.